Picture walking into a restaurant. No menu. No prices on the wall. You order anyway. You eat. A few weeks later, a bill shows up in your mailbox. It says you owe $4,000 for a sandwich. You'd lose your mind. You'd call it a scam. That is roughly how American healthcare works. Before almost any procedure, they hand you a form to sign. Buried in it is one quiet little sentence. You agree to pay for all charges, whatever those charges happen to be. You're signing a blank check, and nobody in the building will tell you the number that's about to go on it. It isn't that they're hiding it from you specifically. A lot of the time, the number doesn't even exist yet. So sit with this. We're a country obsessed with prices. You can compare a flight across 9 websites before your coffee gets cold. So how is it that the most expensive thing you will ever buy is the one thing you're not allowed to see the price of? That's no accident. Somebody built it this way. And once you see how the machine runs, you can't go back to not seeing it. Every hospital in America keeps a document most patients never hear about. It's called the chargemaster. Think of it as the hospital's master price list. Every billable thing the building does lives in there. Every pill, every bandage, every minute of operating room time, every bag of salt water. A typical one holds 10,000 to 50,000 items, each tagged with a code and a price. The people who run hospital finance call it the engine of the revenue cycle. Now the strange part. Almost nobody actually pays the prices written in it. The chargemaster price isn't really a price. It's an opening bid, a sticker number set deliberately wildly high. 3 times, 4 times, sometimes 30 times what the care costs to deliver. One look at the data from 2013 found the average hospital marking its costs up more than 4-fold. A CT scan could carry a markup closer to 30 to 1. Take saline. It's basically salt dissolved in sterile water, and it costs the hospital about $1. On a patient's bill, that same bag has shown up at $90, even hundreds. In one case that made the front page, a hospital billed 6 bags of salt water at $546. So if nobody pays these numbers, why do they exist at all? Try a small experiment. Call a hospital and ask what something costs. Some researchers did exactly that. They phoned more than 100 hospitals asking the full cost of a hip replacement. Most couldn't say. The callers got transferred, put on hold, told to leave messages nobody returned, told the price couldn't be known until you came in. Among the top-ranked hospitals, fewer than half could give a complete number. Among everyone else, about 1 in 10. And the prices that did come back ran from $11,000 to $125,000 for the same operation. The hospitals weren't being cagey. The honest answer is they often don't know their own prices. To understand how a whole industry lost track of what it charges, rewind to the moment the price of medicine quietly floated off from reality. Go back to 1965. The government creates Medicare, and suddenly, hospitals need a standard way to report what they charge. So they build a list, a boring internal ledger. That's the original chargemaster, an accounting tool. Nothing sinister about it. For a while, the list meant something. Hospitals charged, insurers paid, and the number on the list was roughly the number that changed hands. Then came 1983. Medicare looked at its ballooning bills and decided it had seen enough. It stopped paying off the list. From now on, it said, we pay one flat fixed amount per type of case. A hip replacement is worth this. Pneumonia is worth that. Every patient gets sorted into a group, and every group carries a set price. In that single move, the cord got cut. The chargemaster no longer decided what Medicare paid, which left hospitals free to write whatever they liked on the list, because it didn't tie them to anything anymore. The number stopped being a price. It became a fiction they completely owned. Then, the insurance companies turned that fiction into a weapon. All through the 80s and 90s, insurers started leaning on hospitals for discounts. Knock 40% off your list price, they'd say, or we send our patients down the street. Now put yourself in the hospital's chair. If a giant insurer is going to lop 40% off your number no matter what, what's your move? You make the number bigger. You start high so that even after the discount, you land right where you wanted. The insurer brags about the huge discount it won. The hospital quietly pockets the payment it was aiming for all along. Everybody walks away happy. There's just one catch. The list price has to keep climbing, year after year, forever. The whole discount dance only works if the starting number has nothing to do with reality. That's the spiral. That's how a $1 bag of salt water ends up worth hundreds on paper. The number was never meant to be true. It was built to be argued down. Which brings us to the uncomfortable part. If the price is fake, somebody still ends up paying the fake price. So who is it? This is where a weird accounting quirk turns into a sorting machine. When you walk into a hospital, you don't pay one price. You pay a price that depends on who's standing behind you. Got good insurance? Your company already got a deal, so you pay the low, hidden, negotiated rate. On Medicare, the government pays its fixed number, and the chargemaster never touches you. But if you're uninsured, or you wandered into a hospital that wasn't in your plan's network, nobody negotiated a thing on your behalf. So the hospital reaches for the only number it has left. The full chargemaster price. The fake one. The biggest number in the building. The person with the least money and the least protection gets charged the most for the exact same care. While the patient one bed over, the one with good insurance, pays a sliver of it. And the gap isn't a rounding error. Take a colonoscopy. Routine. The whole thing takes about 15 minutes. At one hospital, one insurer's negotiated price came to around $700. At that very same hospital, a different insurer paid more than $1,800. Same room, same doctor, same scope. The price more than doubled depending on which logo was printed on your insurance card. Now zoom out. Across a single American city, the amount people actually paid for that same colonoscopy ran from about $800 up to $8,000. A tenfold spread for one screening. There's a second trick tucked inside the bill, the facility fee. You get charged extra just for having the procedure inside a building labeled hospital instead of a clinic. For the same colonoscopy, hospitals billed on average more than 50% more in facility fees than a surgery center down the road. Same procedure. Most of the difference was the address on the door. And it gets worse, because the trap can spring even when you do everything right. You pick a hospital inside your insurance network. You check every box. And you still get ambushed, because the anesthesiologist who put you under isn't covered by your plan. The hospital was in your network. The doctor standing inside it wasn't. Weeks later, a second bill lands in your mailbox at the full fake price for a stranger you never met. It happened so often it earned a name: the surprise bill. It got bad enough that a federal law finally banned the worst of it, one that took effect in 2022. This is the part that short-circuits people's brains. There is no single price for anything. There are dozens of prices for the same act, and which one you get depends on a negotiation you were never invited to. So a reasonable person asks the obvious thing: why doesn't somebody just force the hospitals to post their prices? People tried, and the fight that broke out tells you almost everything. For decades, the prices weren't only hidden, they were legally protected. Hospitals treated the chargemaster and their negotiated rates as trade secrets. Proprietary. None of your business. When lawmakers were drafting the Affordable Care Act back around 2009 and 2010, they aimed right at this. The logic was simple, almost sweet. If patients could see prices, they'd shop around. Competition would drag the costs down, the same way you'd book a hotel room. It took more than a decade to turn that idea into an actual rule. Finally, on the 1st of January 2021, it landed. Every hospital in America, roughly 6,000 of them, now had to publish its prices. Not just the made-up chargemaster number, the real ones. The secret rates they'd negotiated with every single insurer. Posted in public, in files anyone could download. The hospitals did not take this lying down. Their association sued, calling the rule unconstitutional. They pushed the case as far as it would go, and in December of 2020, they lost the final appeal. So the prices came out. Problem solved. Except it wasn't. Because there's a wide gap between obeying a rule and complying with it. Hospitals technically posted their files, but in thousands of clashing formats with mismatched labels, missing columns, and codes no ordinary person could read. Some of it was so scrambled it was useless. When researchers went digging, they found the large majority weren't really complying at all. Call it malicious compliance at industrial scale. Sure, the door is open. Good luck finding the light switch in the dark. Then the rule got a sibling. A second mandate forced insurers to post their negotiated rates too. Both sides of the table were finally supposed to show their cards. And still, the numbers stayed buried under mountains of unreadable data. So the regulators pushed harder. They raised the fines. They opened compliance actions against more than 5,000 hospitals. The pressure kept building. And then the rules finally grew teeth. In early 2025, a new executive order came down with a long name and a blunt goal. Make the prices real. Make them accurate. Make them something a normal person can actually compare. No more vague estimates. No more trust us. By late 2025, the regulators finished the job. Starting in 2026, a hospital can't post a fuzzy guess anymore. It has to publish real dollar figures. The median price for a procedure, plus the 10th and 90th percentile. So you can finally see the spread of what people actually pay. And a named senior executive, usually the CEO, has to sign their name to it and swear the numbers are true. Enforcement of the tougher version kicks in on the 1st of April 2026. After 60 years, the hidden price list is finally being dragged into daylight. That sounds like the happy ending, the big win. But there's a trap waiting here, and it's a clever one. A posted price only matters if you can actually use it. You can't comparison shop from the back of an ambulance. You can't haggle while you're unconscious on a table. You don't know in advance whether the surgeon finds one problem or 3, whether you'll stay 1 night or 5. And most of the time, you don't even pick the hospital. Your doctor does, or your insurance plan does, or your emergency does it for you. Healthcare breaks every rule of a normal market. In a normal market, you know what you're buying, you know the price, and you can walk away. In a hospital, you often know none of those 3 things, and walking away can kill you. There's a deeper problem hiding underneath all of it. Transparency assumes the high prices are a mistake, an accident of darkness that a little sunlight will fix. But what if the darkness was never the bug? What if it's the whole design? Remember the spiral. The entire model runs on different people paying wildly different prices for the same thing. The insured pay one rate, the uninsured pay another, the government pays a third. That arrangement only holds together if nobody can lay the prices side by side and compare them. The secrecy isn't hiding the system. The secrecy is the system. Pull it out and the whole thing falls over. That is exactly why the hospitals fought so hard. They weren't protecting a spreadsheet. They were protecting the machinery that lets one quick colonoscopy be worth $800 and $8,000 at the very same time. Now, to be fair, the hospitals do have an argument. Those inflated prices, they'll tell you, help cover the things nobody pays for directly. The emergency room that can't turn anyone away, the charity care, the research. the patient with no insurance and no way to pay. Charge the well-covered a little extra, the thinking goes, and you keep the lights on for everyone else. There's truth in that, but it doesn't explain why the prices have to be a secret. You can spread those costs around in plain sight. You only need the fog if the fog is doing quiet work for you. And you are paying for all of it, even if you've never laid eyes on a chargemaster in your life. You pay through your premiums, which creep up every time a hospital wins itself a fat, negotiated rate. You pay through your deductible, the slice of the fake price that lands on you before insurance even wakes up. You pay through your taxes, which fund the government programs covering these bills. And tens of millions of people pay the most direct way there is, through medical debt. It's the most common kind of debt that drags Americans into collections. Not credit cards, not car loans, hospital bills. More than 100 million people in this country are carrying some of it right now, for a thing they were never allowed to see the price of before they ever agreed to buy it. The prices are finally being forced into the open. The files are going up. The numbers are slowly getting real. But the deeper question is the one nobody inside that hospital wants you to ask out loud. If the price was always fake, if the same exact care can cost 10 times more depending on who you happen to be, if the confusion was the product all along, then what exactly have we been paying for?